Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
In order to prevent the spread of the virus, we all need to do our part. One of the easiest ways to prevent that is by wearing a mask. In order for a mask to do its job, it needs to cover your nose, your mouth, and your chin. First, you should wash your hands with either sanitizer or soap and water before putting on a mask. Then pick up your mask by one of the ear loops to make sure that there's no tears or stains on the mask. If it is dirty, throw it away immediately. If it's intact, take both loops and put it over your ears like this, and then press down on the bridge of the nose to make sure that it fits and there are no gaps. Once you are done with the mask, please take it off the same way. Both ear loops, pull it away, and put it either in a Ziploc bag or throw it away if it's a surgical mask. If it's a cloth mask, make sure to wash it with soap and water and keep it dry for the next use. Do not put your mask down at your chin or above on your forehead when you are starting to remove it, as that just contaminates the mask. Thank you so much for doing your part to prevent the spread throughout the city.
And that was the lovely Dr. Days explaining to us why it is that we need to wear our masks, and it is very, very important. And I like how she so beautifully took it away from the ears, and it's so true because so many try to grab their masks from their face. That's not the way to do it. So thank you, Dr. Days, for doing that. Well, how often do you get to speak to a neurosurgeon? Tonight we get to speak to two of them, and I'm very excited about it because it's always something new that we get to hear about. Neurosurgery is a specialty dedicated to the diagnosis and treatment of diseases and injuries affecting the nervous system, which includes the brain, the spines, the nerves, and the muscles. Often we don't think about the spine as neurosurgery type stuff. We always think that's an orthopedic type situation, but spine surgery is a big, big deal in the world of neurosurgery. There's that spinal cord in there too. You'll see this evening that we have neurosurgeons who do a lot of work on both the brain and on the spine. We have a pediatric doc with us this evening and a grown-up doc with us this evening. During this hours, we have all kinds of questions, and it's all about the advancements of neurosurgery here in El Paso. And as you know, this is a live program, so if you have a question to think of this answer or this evening, give us a call at 881-0013. This evening's program is underwritten by the University Medical Center, and we also want to thank the Texas Tech Paul L. Foster School of Medicine for providing the medical students to man our phones, and as always, the El Paso County Medical Society for bringing this program to you. Good evening, I'm Catherine Berg, and you're watching the El Paso Physician. Again, thank you so much for joining us. Neurosurgery is our topic this evening, and I want to give a shout out to Kristen Hemsdorfer, who is here. She is our medical student who will be answering on the phones, and what she is going to be doing in this world of COVID, we're going to try not to pass papers back and forth so much. So you will see me addressing my phone quite often, and I'm not texting my kids or my friends or what have you. This is how the questions are coming my way, and Kristen is the one who's going to be answering the phones for you. So feel free to call in with your questions. Live program 881-0013. We're also streaming right now on YouTube, and there's going to be several ways that you can watch the show again in the future because of YouTube and also because of the County Medical Society and PBS El Paso. So with me today we have Dr. Todd Trier, and he is a neurosurgeon. And we have also Dr. David Jimenez, who is a neurosurgeon specializing in pediatrics. So on that note, I would love for you, Dr. Trier, you're talking about being originally from Montana, and before we were on the air, we thought, El Paso, it seems to be nicer and easier to recruit doctors to El Paso because we're in such a beautiful renaissance right now of all the great things happening in El Paso. So if you can just briefly go through your career, and why did you choose El Paso?
I went to medical school in Tucson. I did my neurosurgery training in Galveston. I was a cerebrovascular and skull-based fellow at the Barrow Neurological Institute then. I practiced quite a few years in Wisconsin. I took a year off and came to El Paso. It was a lot more sunshine in El Paso, and they needed a little neurosurgical help.
And as some of the medical students will say, there is no mole like there is in El Paso. That and enchiladas and tortillas and all the other great stuff. So I'm glad that you're here. And Dr. Jimenez, we talked last year a little bit. You were here right around this time last year, and we stole you from San Antonio. Correct? But originally you said you were from the city of the brotherly love. I love that. So how has your path kind of brought you here?
Yeah, so grew up in Philadelphia, and I went to undergraduate there at Temple University. I did my medical school there and my residency in neurosurgery. And then I went to New York at Albert Einstein to do my fellowship specialized training in pediatric neurosurgery. I spent about 13 years in Missouri.
In Missouri, okay.
Yeah, I was at the University of Missouri. I've been in academics all my life. And then I was in San Antonio as chairman of the department at UT there, in neurosurgery, for 15 years. And then last year I came here.
And you've loved it ever since.
I really have. It's
Yeah.
a wonderful town. You're correct.
So people who are not from Texas think that San Antonio's got good Mexican food, but nowhere near, right? I mean, that's something
absolutely, yeah,
needed to hear that. That's just one of those
Absolutely.
things. I wanted to, and you all beautifully brought this up, I wanted to clear some things up. So there's neurology, and there's neurosurgery, and then there's the neurosciences, which is the study of everything underneath there. So I'd like to kind of start with that. It may seem too basic for this table, but I think it's really nice for the audience at home, including myself when we were just talking about it prior to the program. What exactly is the difference? So Dr. Trier, I'll start with you. So neurology is one thing, neurosurgery is yet another. If you can explain the difference between the two.
Sure. Neurology would be treating all neurological diseases that don't require surgical intervention. Neurologists and neurosurgeons work quite closely in some specialties. Neurosurgery then is all about the surgical treatment of those neurological diseases. Tumors of the spine, tumors of the brain, degenerative conditions of the spine, compression of nerves in the hand, in the arm, and of course all of the trauma that happens to the brain and the spine with injuries.
Okay. And do you feel like, and we'll go through this during the show too, a lot of what you're dealing with neurosurgery, are most of those things because of injuries, would you say? Or are there, because I'd like to talk about some diseases this evening too, and just things that happen to the body. But those that are trauma induced versus those that are induced in any other way.
We have a large trauma practice as a consequence of supporting UMC and their level 1 trauma program.
Okay.
Our emphasis, though, has been in developing our elective spine practice. About 2/3 of what we do week to week is spine related. And it's probably 50-50 at this point, but growing in the elective side, but 50-50 with regards to degenerative spine problems versus traumatic spine injuries.
So you just brought up a beautiful point for me. When someone says the elective side, so that is when you've got some degeneration of discs. Elective is, we could put it off, better to do it now. Is that what you're talking about with the use of elective surgery?
Yeah, that's right. Okay. We want to be coordinating the interventions for pain-related problems of disc herniations in the neck, disc herniations in the lumbar spine, wear and tear changes that happen in our working populations. Just everyday use of our spine is going to put those degenerative changes to happening over the course of our life.
And that's nicely said too, because it's happening to all of us. I joke, and I think we talked about this last year, the left side of my everything is messed up. I've got a good scoliosis curvature going on, the squishiness is going away. Dr. Jimenez, I want to talk about your specialty. We're already starting to get some questions here from the audience, but I want to talk about your specialty in pediatric neurosurgery. It almost seems like, wow, you know, a child that needs neurosurgery is just a scary thing. It's what you do all day, every day, and I'd like for you to maybe talk about some of the issues that you run across when it comes to pediatrics and neurosurgery.
Yeah, that's a great and excellent point. One of the things that we always say in pediatrics is that children are not little adults.
So true.
That's very different.
Right.
And the reason why we say that is because kids are completely different creatures in terms of the diseases that they get, the problems that they get, and the tissues, the body is different, the anatomy is different. So it's not like we're operating on little tiny people, adults. So the kind of things that we see really are completely different than the stuff that my adult counterpart will see.
Right.
We get a lot of what's called congenital problems. So things that the development of the nervous system in utero goes right. And then when the kids come out, they come out with all these different, absolute different things in the brain and the spine and the spinal cord. And so we need to treat all of those things, which are very different.
Is there ever, and I might be going off tangent a little bit here, but you were talking about in vitro. So when the child is still in the mother, how often are there abilities to see if there's going to be an issue once the baby's born?
Oh, indeed, these days.
I feel like, yeah, that's what's...
Matter of fact, yesterday I was looking at a set of MRIs of a baby who is about 23 weeks.
Oh my goodness, okay.
Know? But the mom had an MRI, and looked at this baby. It was looking like an entire human being in there, the brain, the detail of all the things. So we can tell very early on. Now, ultrasounds gives us some idea, but if we do a maternal MRI, it's absolutely beautiful. You can see everything.
So that's the word, maternal MRI. Are you ever able to fix anything prior to birth?
Well, yeah. So in pediatric neurosurgery, there's been a group of neurosurgeons, particularly at University of Pennsylvania in CHOP, Children's Hospital of Pennsylvania, Philadelphia, and in Vanderbilt, where they've been working and they've been doing this prospective studies and doing fetal medicine in kids who are born with spina bifida.
That's exactly where I was going. So
the spinal cord never closes and is wide open, and these kids get what's known as hydrocephalus, fluid in the brain. So we're doing the surgeries in this case, we have to open up the mother, take the baby, do the surgery, put the baby back, and then it shows improvement in the rates of development of hydrocephalus and other associated conditions, yeah.
It just impresses me so and fascinates me so when I get to, every now and again get to watch a video or something that gets sent my way of surgeries that are being done on a pregnant mother, on the child. And just before 20 years ago, that wasn't something you really could do, with the robotic surgeries and everything going from there. So I find it absolutely fascinating. I'd like to ask Dr. Trier, so there are a lot of things at UMC that are happening right now. Like you were talking about the last several years, you're concentrating a lot on spinal surgeries. And so we talked, I'd like to talk about some of the, congenital is a word here, but let's say that there are just fractures that start happening as people get older. Or maybe there are fractures that somebody had a year or 2 or 6 months ago and just now are starting to get to come see you, that they're really starting to display some symptoms, etc. Maybe just talk about a few of those that are most common that people in the audience might be feeling.
Sure, happy to. I have presently a 53-year-old woman who came to see me with progressive difficulty walking, tolerating upright positions, and on her x-rays, the L4 and the L5 vertebrae were slipping relative to each other. We call it spondylolisthesis. And it's a developed wear and tear problem in such that a way that the joints don't hold us upright adequately. And so they just start to slip. And with that slip, then there's the nerves in the canal that get pinched, and there's the nerves that are exiting at that 4-5 level that are getting pinched. So fixing that then is a matter of giving those nerves some more space and then preventing those vertebral bodies from moving anymore.
And when you're in there, when you're talking about moving the spine and the different are you adding material in there? I mean, I'm thinking about cushions. Are you adding material in there, putting screws in there to hold things apart? How exactly are you doing that?
Sometimes we're putting screws in there. Sometimes it's been a condition that's been there long enough that the vertebral bodies have fused on their own.
Okay.
So the primary emphasis is to give the nerves in the sac more space and the nerves that are exiting more space.
Right.
And that's it.
Okay. And it seems like such an easy surgery when you talk about it. So here's another question, because I am one of them. I'm 53, so we can even say that I'm this 53-year-old. Waiting and waiting and waiting until it's bad enough. And so I'd love to hear some of the stories that patients have come to you with and thinking, you know, I've been having these issues for X number of years. What is it that makes people finally come to you? And what advice can you give to others thinking you don't have to wait this long, we can fix this?
Yeah. The part of the problem with patients in our particular area is that we have a very high number of patients who are uninsured. And so the last thing you want to do is spend money on a spine problem that's been going on and you've been managing for a while.
Right.
So that's part of the problem. But just going to get help doesn't mean that you're committing to an operation.
Right.
And that's one of the important things about educating patients about spine problems, about leg pain, about back pain. There are many things that you can do along the way to get your muscles to do their job, to move you around, rather than depending on the joints and the discs and the bones for that support. And oftentimes, you know, and the studies show it as well, these sort of awareness and teaching is what helps to start turning these patients around, helping improve their pain syndromes.
Okay. Pain syndromes. What a word to use. Dr. Jimenez, just because I want to kind of go back and forth on this, I would like to ask you about trauma and pediatric neurosurgery. So what kind of accidents, I mean, I know that there's car accidents all day long, but some of the most common traumas that you see coming through that you need to fix now, and I know with neurosurgery, time is always of the essence, you know, because you want to make sure that things get back in place as quickly as possible. But some of the case studies that you've had to deal with.
Yeah, just like adults, kids get injured a lot. And there's something that is very unique about kids, especially little kids. When you think about the proportions of the body, right? If you look at us, we have a big body and a relatively little head and strong neck.
Right.
Little kids, on the other hand, have little bodies and big heads and very lax necks. So anytime they're in a situation where there is a lot of movement back and forth in a car accident, falls, non-accidental trauma, i.e. child abuse, things of that nature, it tends to cause significant problems to the neck and to the brain. One of the things that we see a lot, unfortunately, are all-terrain vehicle accidents.
Oh, gosh.
You get all these kids going out there, no helmets. They think they're invincible and they're running around flipping things, and then next thing you know, they get damaged severely in their brain, their spines, they get broken spines. So we see a fair amount of that here, accidents, trauma, falls, so just everything in general.
So here, and this may be a simple question, but diagnosing what exactly is wrong, I feel like that's a hard thing to do. So you've got the MRIs, you've got the CAT scans, you have the clinical way of looking at a person, their eyes, you know, et cetera. But if there's been an accident, and aside from the obvious things that you can see, how do you diagnose what is wrong and what you need to fix? Is that, am I,
yeah. Well, first of all, it's a physical examination, right?
Yeah.
You look at the kid.
Aside from being able to just see that,
so we get a pretty good idea what the patient has, right? But based on what we see. And then we have to confirm it with imaging. And most of the time, it's either going to be with a CAT scan of the brain, That's the
Right.
first thing we do. It's very
Okay.
quick to get, and or with an MRI.
Okay. Okay. Dr. Trier, I was starting to get some questions from the audience, and I'm going to go to the one that is most related to what we were just talking about. 65-year-old person on the phone doesn't say if they're male or female, and I'll give out my disclaimer. So in the old days, I had a card that was like this size, and I said, this is all the information we have on the card. These are my babies, by the way. Just thought I'd show that since that's on the air. But that's all the information that we have. So here we have maybe 2 sentences, and that's what we go on, and we do the best that we can answering that question. But question from the audience, 65-year-old, does cervical herniation cause pain and disability for the rest of your life? And I guess I'm going to read into that as if I should do something about it, should I? Or is this going to last for the rest of my life? So once you start getting pains and the herniated discs, that's not going to go away. It's not ever going to get better on its own. Correct? Or would it?
Well, I consider some of these as mechanical problems or as sort of musculoskeletal problems. And telling the two apart really is a conversation with what's going on with the patient, okay?
Mm-hmm.
So posture,
Right.
okay? Yes.
Yeah.
Our adult working life
Yes.
is all of this humped over stuff,
Yeah,
right?
absolutely.
Cooking, computers, sorting, concrete work, all of that is
Yeah.
this humped over stuff. If we put our head in front of our spine, that isn't the way the spine is made to support itself.
Mm-hmm.
So if you get these muscles doing their job to correct our adult working life postures,
Mm-hmm.
then a lot of these pain things start to subside. So my first off answer for this caller would be, no, it's not my expectation that someone put up with pain day in and day out. Let's have a conversation.
Right. And then also, so I'm hearing a little bit about physical therapy. And it's funny you said posture, and I'm like, immediately, okay,
Yep.
I'm going to do this, because I am that girl. And again, a lot of that's in the neck and the head is so heavy.
Yep.
And we just take it for granted because we always have it in this position. So when people are looking at, and even I've gone through several physical therapies, and it's great because you're doing it for 2 or 3 months, and then 8 months later you're like, oh, I forgot about those
That's right.
exercises or this, and so the following year it's in the same situation. So
That's
if you're
right.
really good about the posture, now that I'm sitting next to you, I'm going to stand up straight. That's good. And so a question here from the audience too is, and Dr. Jimenez, I'm going to hold on just a second with you. Question is seizure disorders. That's not something we've talked about yet. Although let's talk about kids with seizure disorders as well. We can actually bring both of you guys in here. But the question is, do neurosurgeons work with seizure disorders, or is that a neurologist? So that kind of comes into the question that we talked about right at the beginning of the show. Who wants to take that first?
I'm happy
Dr. Trier, okay.
to start with it.
Okay.
It's definitely in the purview of neurosurgery.
Okay.
Because the consequences of brain tumors, the consequences of traumatic brain injury can definitely be seizures, right? And the thing that I like to convey to patients is that you have to set things up to suppress the seizures.
Right.
The more seizures that you have, the easier it is for your brain to have seizures.
Right. Which is
So-
odd.
Yeah.
So I'm interrupting you, but why? I don't understand that. So when you have seizures and you're just going to have more and more, why is that?
Well, the brain learns.
Okay.
And these patterns of electrical pathways excited in a seizure become oriented toward that electrical activity. Okay?
Interesting. Okay. So it like becomes a memory, like you said.
Yeah.
It becomes muscle memory or
Yeah.
nerve memory
Nerve
at
memory,
that point.
yeah.
Nerve memory. Okay, so when we're talking about kids,
Yeah, so one way to look at it, and when I talk to my patients, I like to use analogies so things make sense. So it's a good way to think about dividing the world into black and white. And for me, would be dividing the world into medical and surgical. So say a patient comes to us and the patient has headaches, and horrible, horrible headaches. So then we do an MRI, and then we find out the patient has a tumor the size of a grapefruit. Well, that is, how do we treat that?
Right.
We take the patient to surgery, we do the craniotomy, we take the tumor out, take care of the headaches. That's a surgical headache.
Right.
Another patient comes to me, headaches, same thing, and it turns out that he has migraines. Well, I can operate on that patient 10 times, and the patient will always have migraines because that's not a surgical problem.
And that's still a mystery too, where the
What-
migraines are coming from.
Yeah,
Or,
well, we know a lot about
okay,
it.
all right.
But that's not a surgical problem.
Right,
That's
exactly.
a medical, that's
Yeah.
treated with medicines and all that. So as far as the question about seizures, at least in kids, yeah, there are a group of seizures that are caused by structural things, tumors, cysts, hemorrhages, vascular malformations, so on and so forth, that the treatment involves doing surgery, removing the offending lesion, and then taking care of the seizures. Now, there's a whole host of things that affect the brain that have nothing to do with that, and they're basically problems with the electrical conduction of the nerves and all that. And that's treated with medicines. That's treated by neurologists.
Okay,
So it depends on what the patient has.
okay.
Does that
And
make
if-
sense?
It does make sense, and I'm just trying to think of when I was a kid, and there was a kid that maybe many of us knew. It's like, oh, that's a guy that's always got seizures. Whether at the time it's epilepsy, that's what we knew at the time. But then there's you just see a seizure happening when you're in high school, and you wonder, okay, what's happening to that? Let's say he's under the age, let's 16-year-old. He's a 16-year-old.
Right.
He's on the track field, and he's running, and all of a sudden he's down. He's having a seizure. And so if you're one of the 100 people around, and you're the doctor, what would you say is happening? I know you don't know, and again, it's kind of like that little question here, but what would cause a seizure in someone who's never had one before? Healthy kid, and it's not that you have the answer. I'm just trying to think of what could be some of these causes.
The list is long of things that can cause it.
Like, Catherine, that's a whole nother day.
No, and we could give you a list of names, but the point
Yeah.
is we need to do the workup.
Right.
And one of the main things is to find out if there is a structural problem. And one of my goals here is to establish a program, an epilepsy program, where we work closely with the neurologist, the neuropsychologist, and a group to take care of these kids in a global manner rather than just one person independently. So
Right.
we'll be having hopefully that in a near future.
So if you were able, on that note, if you were able to describe what epilepsy is, how would you describe that in a couple of sentences?
A bunch of excited nerves.
A bunch of excited nerves. So
And then
nerves that just
they
want
just
to.
start firing, and
Okay.
depending on which nerves are affected, if, for instance, the nerves right here that control my hand get fired, then I'm going to have a tonic. If it's one that affects other parts of the body, maybe my legs will shake, or my speech will get affected, or I may just pass out.
Okay. And we may or may not know what the triggers are. I know that there's anti-seizure medications that people can get on. But are there specific triggers, especially in young ones?
There are some that are affected by, lights.
Like lights, because it's what I think about, movie
Yeah,
theaters,
lights
that there are
can be-
certain movies that, okay.
Too much computer work, games.
Yeah.
Kids who get into those games and the constant stimulation. Yeah.
All right, now I have a senior in high school who's zooming through his senior year, but he's on screen 7 hours a day. Not by choice, but it's just on screen all the time. Question here from the audience, 66-year-old female is asking if she should go to the orthopedic surgeon or to a neurosurgeon. She wants to know about spondylarthropy. Am I saying that right? It's S-P-O-N-D, spondy, and then laryngopathy. Does that make sense to you? It says small fractures at the L5 and the S1, question mark. If this is something we don't know, we don't know.
Right.
But we can move on. But you want to give a stab at that?
It sounds like
Okay.
spondylolysis.
Okay,
Okay.
okay,
And that's a fracture of the tip of the joint of L5
okay.
that prevents L5 from moving forward on top of the sacrum.
I'm going to get up, keep talking. There's a
Okay.
little tiny I have a spine behind me.
Yeah. And if,
I've got wires and mics going to town.
yeah.
Just throw that in your way there.
That happens at this joint right here.
Okay.
Between L5 and the sacrum. Okay? And again, just like the spondylolisthesis that we talked about earlier, if you prevent that bone from moving any longer and you take the pressure off of the nerves at that level, then those nerves are much, much happier.
I like the way you say that. So they should see, so her question is orthopedic surgeon, neurosurgeon, because this is where you're talking about making that space
Yeah.
for the cord, for the nerves,
I'm
for all that good
definitely
stuff.
biased toward neurosurgeons taking care of spine-related problems.
Okay. And that makes sense to me too. I keep saying that I need to come see you guys because I'm that person. It's like, well, I can hang with this for a little while longer. I don't know if this really matters in this world. So when people are talking about the brain barrier, the brain-blood barrier, does that have anything to do with nerves at all? Or is that literally just an infection fighter? Because I think of brain surgery, I think of spine surgery, and then I think about when we talk about chemotherapy and that's a thing. Is that something that is in your world at all, the differentiation between the brain and the spine when it comes to relief?
Well, with regards to the blood-brain barrier, it affects how and the kind of things that we use to treat the brain. All right? The blood-brain barrier is one of those things that makes the brain special. It's not like the liver. It's not like the lungs. It's a membrane that literally separates the brain from everything else.
Okay, so it is still a separate thing. Question here, I want to talk about, so you two are both neurosurgeons. You have the same job. You work basically with pediatrics and kids. But what I'd like to know, and for the audience at home too, is what is your team? Like, who is it? What specialties do you have on your team? And you're welcome to give out, again, a case study or an analogy. It starts with the nurse that does prep, that goes here, that goes there, and then there's therapists that come and go before and after as well. So talk about the team that you work with.
Well, first, I can't really do my job except that all of these many, many people show up to help me do my job day in and day out, right? If patients are coming to the clinic, then there's our intake people and our medical assistants who will take the vitals and take the statistics from the patients. There's the nurse in the clinic. We have 2 nurse practitioners that help us in the clinic, and we have 5 nurse practitioners that help us in the hospital.
Right.
We rely on the patient's primary care physician to help us work up those patients prior to the operative date to assure us and assure the patient that a general anesthetic is in their best interest. When those patients get to the operating room, we have the nurses in the pre-op holding area.
Right.
We have the surgical techs and the nurses in the operating room. We have the anesthesia personnel, both the anesthesia physicians and the CRNAs who are managing the patient minute to minute in the operating room. Oftentimes, many times there's a representative for specialty instruments that we use in the operating room for navigating the brain,
that's a
for
good point, right.
navigating the spine. We have radiology techs who are doing some of those special x-rays for us in the operating room. We have surgical assistants helping to keep all of our instruments organized on the back table, passing things forward and backwards, people helping us with our microscopes, with our overhead cameras to make sure that we're getting good pictures, the right amount of light. And then we move to the post-operative care, right?
Right.
The ICU, the critical care people in the ICU, the nurses on the floor, and then the physical therapists, both inpatient and outpatient, that are helping us to rehabilitate our brain tumor patients, our trauma patients. A lot of integrated effort goes into taking care of these patients.
And once you get to the point of physical therapy after you've had surgery and you've been in the hospital for a while, what I've always really liked is that there are quite a few physical therapists that go home with you, kind of scout out the house, figure out what it is in your house that you should move or take out of the way. I like that because that's so human, because then you're involving the entire family. Because it could be the 53-year-old. We keep going back to this person. It could be the 53-year-old, and maybe she's got her 79-year-old mother living with her, and then she's got her kids, and then their kids. So I think it's always fascinating that that's part of the case. Dr. Jimenez, I read here that UMC has got some new technological advances, and I'm assuming this is in the pediatric area. So I'd love for you to talk a little bit about that. That's always fun. I feel like Spock.
Before I answer that,
Yes.
if I may give a shout out to a group of folks that we work with very closely and who are very critical to what we do, those are our surgical technologists. And this is Surgical Technology Week, so.
This is Surgical Technology Week.
Yeah,
Happy
so
Surgical
congratulations to
Technology
them.
Week.
Yeah,
Well, there you go.
But they really are incredible because we work one-on-one. They're the ones handling the instruments, and their input is critical to our success. So
It's like a really good caddy,
Yeah,
right?
right.
They
Yeah,
know
exactly.
that they have to know what they're going to
Exactly.
give you. And if they give you
Exactly.
the wrong thing, it's the wrong shot.
Right.
So yes, you're right. A big shout out to them.
So, what was your
So I was
question?
talking about the new, everything
yeah,
that's
next-
happening in
next
the
time.
forefront of technology, new technology in this area of study.
So one of the things that's very unique about neurosurgery, right, is that we need a lot of instruments to do our work.
Right.
And so neurosurgeons and their toys, we have very expensive toys because the things that we use are very complicated, very complex, right? It's not like just taking the patient to surgery, open them up, doing the surgery.
Yeah, it's not, you just have a scalpel and that's it. Right.
So before coming here, there were a lot of, the Children's Hospital didn't have a whole lot of the instrumentations because no one was really, except for the team there, was doing the basic needs of complex pediatric neurosurgical cases. So in order to do that, it required quite a bit of investment by the hospital, and I'd like to acknowledge that they've really gone a long way to fundraise and to come up with millions of dollars that it costs to get the equipment that I need to do the kind of work that I do. I mean, literally, this is, we say 21st century. We are in the 21st century, but way
You can
ahead
shoot for the
stuff.
22nd century.
Right.
Yeah.
So, for instance, we just got a very expensive piece of equipment that allows us to do surgery. I mean, literally, the equipment we can hone down using 3D glasses and see things that, I mean, almost literally you can see the red cells flowing through the vessels.
Wow.
I do a lot of endoscopy, which is minimally invasive surgery.
See, we didn't talk about that at all, and I would not have thought that you do. Okay, so talk a little bit about that.
So there's several areas. That's one of my areas of interest and expertise
Okay.
in my career has been to do minimally invasive surgery. Just like when they used to take gallbladders out through those big incisions, and then they started doing
Right.
the right little. So we started doing the same thing in the brain. So instead of doing these big openings, we try to go in there through an opening the size of a dime, putting in miniature telescopes, lasers, and doing all the work. That's kind of the things that I do.
Interesting.
That costs, those equipments are extremely expensive.
Right.
So this past year, the hospital really has made an effort and brought all the equipment that's needed, and I am now doing very complicated, very extensive surgeries that were never done here before, and I have patients coming from all over to do that.
And you made me think too, and Dr. Trier, I'd like for you to jump in on here too. So I feel like there is ever upcoming new technologies, but then there's trainings, right? All the trainings that come with the new technology that's there. Like how, I'm not gonna say how many, but when you have an average 5 years, are you going to trainings because there's new toys, there's new you're talking about the people that are handing you the instruments, you know, they're obviously being trained all the time, but how does the training work in your worlds?
Most of the neurosurgery meetings have workshops ahead of the meeting schedule. So that's one way.
Okay.
The second way would be to go to different schools or different workshops that are sponsored around the country for pituitaries, for skull-based tumors, for minimally invasive spine approaches, approaches from in front, approaches from the side, some of the endoscopic courses for spine work. And the third way would be that the spine companies bring a truck and we do cadaver work in the truck in the parking lot at the hospital.
Interesting, and that way you can have your team all there at one time, because these are the people you're working with anyway.
Yeah.
That's great.
Yeah.
That's really great. And how about you with trainings?
Yeah, well, I've been the one doing the training for many years.
Well, who trains you? Somebody has to train you originally, though, right?
Yeah, well,
it's just an act of God. It just comes down.
The residency, but so being in academia, you know, I've been teaching, like he said, courses all over the world and all over the country. But to that point, for instance, there's a number of operations that I invented a number of years ago. And so a lot of pediatric neurosurgeons and plastic surgeons and oromaxillofacial surgeons and ENTs are interested in learning that. So we plan to have, for instance, to what Dr. Trier said, we were going to have now a 2-day course where surgeons come from all over the world, and I do 2 live surgeries.
And that's here in El Paso?
We were going to do that. We're going to do that, but COVID kind of put a squash to that.
I get
But we're
you.
going to do that next year as soon as things settle down.
Right.
But the idea, for instance, is we have the surgeons come from all over the world. They stay here with us, and then we have a live surgeries where they can actually see what's going on live. And then we have all-day lectures and courses, okay? And then we have another day we're going to have hands-on with models that they can practice, and when they leave, and then they leave with all the materials so they can go back and do it. That's how we teach each other.
I think that's fascinating how you all do that. I just lost internet connection here. So we are at about the 14-minute mark. So what I'd like to do is kind of stop these questions here and really concentrate on something that you'd like to talk about that we haven't talked yet about, or we can, you know, further expand on something that we did touch base on. But it's always that time where I feel like we really need to make sure that what you wanted to have come across this evening comes across. And it's just because it's bounced back and forth. Dr. Trier, you get to go first.
Okay. Thank you. Well, I want our medical community to know that we're the largest, most experienced neurosurgical group in a very wide area. And to that effect, then, we're also able to go to outlying clinics that we've just started doing this month.
Oh.
Fabian's Clinic, our UMC East Clinic. We're exploring the Northeast for a location and doing clinics at the UMC West Clinic as well.
And so these clinics, talk a little bit more about what these clinics, so how equipped are the clinics? Or is that something that you're getting into the point of that's something we're just starting?
Yeah, it's something that we're starting, and largely just giving patients more opportunity to access our neurosurgical clinics is the idea. We still are getting x-rays and CTs and MRIs as a result of that clinic visit or through the referral of the primary care doctors. So how they're equipped is really, you know, we bring an MA and we bring a nurse and our surgeons show up and we see patients, and even a Saturday clinic on the east side. We're starting as well with the idea that, look, we want to make it easier for people to come and have this conversation about how to help with your neck and back.
Right. So you can start it there for people who, it's intimidating to go to a big hospital.
It
so
is.
it's really nice to be able to have some kind of a, advice being given. And if you do need to go to the big hospital, at least you saw somebody first that kind of gave you some advice first.
That's right.
Nice. Okay.
So second thing that we have going on is our new UMC Surgical Center West
Okay.
on Mesa.
Yes, I've seen that.
And,
Okay.
and we're going to start doing injections
Okay.
and day surgery procedures at that facility about February next year. And that will definitely make our neurosurgical services a lot more accessible to patients at large. No longer have to go to a hospital to get your procedure done.
Okay. And that's a big thing too. Going to the hospital is always the scary thing. Getting a couple of questions from the audience. Sorry, I know it looks like I'm not paying attention to you. Dr. Jimenez, what is it that you would like to talk about this evening before we close shop? Is there anything that you'd like to get across to either parents, to the general public, in what you do here in El Paso?
Well, I guess first of all, at the beginning of the program, you mentioned that you were saying to us that you felt like El Paso now things have changed, and then there's more people, more doctors, and that is happening. I think we're at a pivotal point. Case in point is I'm here, right? Providing the services that are so needed. I mean, I could have gone to LA, I could have gone to New York, I could have gone anywhere else, but I knew the need was here. And so you go where the need is. And I must give credit to the administration of UMC and Children's for seeing that and putting the money and time and commitment behind developing the program. So all the things that we're able to do now for this community, right, are things that a year ago or a year and a half ago we couldn't do. And so I want everyone to know that the city is really moving forward.
It really is.
In a great way. So it used to be, from what I hear, that people just left town to go get medical care a lot of times, and now people are flying into here to get the care. And so it's nice to know that
I love
we
your
have
chuckle.
that.
That's true.
I
That's
know
good.
that we have that,
Yeah.
and that we're growing because, hey, if I get sick, I want to be able to stay here and get treated
You
well
want to be
here.
able to do it at home.
Right.
That's right.
And that
Absolutely.
is happening. And for the kids, certainly, they're affected with neurosurgical issues, neurological issues. That we have that now, and
Yeah.
I want everyone to know that.
I couldn't agree with you more. I work with the El Paso Community Foundation. That's my day job. I do this as a volunteer. But part of what we do is trying to just bring everything that we can to El Paso to make this region better. And I've been there 10 years, and I feel like every year there's something more to brag about. So kudos to both you guys for being here. I love that. A couple of questions here from the audience. I'm going to go, person had an aneurysm and survived. Are there any predisposed conditions that can now come after that? So again, that is a very, very broad and very not a lot of question there, but Dr. Trier, you're getting that one, sorry.
Okay.
So maybe explain first what an aneurysm is.
Sure.
Yeah.
An aneurysm is a weakness in the wall of one of the blood vessels in the brain. The nature of aneurysms that occur in the chest or the abdomen is very, very different than the kind of aneurysms that occur in the brain. There are three primary ways to treat aneurysms, right? One is to watch it. That is, if it hasn't ruptured, okay?
So you can tell on a CAT scan or an MRI that there's a bump there, that it's going to happen eventually.
Right.
Okay.
That's right. The second way to treat these is through endovascular coils, little platinum wires that you put into the inside of the balloon of the aneurysm to slow down flow and stop the growth.
Okay.
And the third way is sometimes the aneurysms are configured in such a way that coils are not possible. And so you do the operation to reconstruct the wall of the blood vessel.
Okay. So when you're talking about, I'm actually going to the next question, because I'm thinking to myself, once the aneurysm is taken care of, say 10 years has passed, and you know that there's already, it's been fixed for the most part, is it something that they keep watching throughout their lifetimes? Is it something like every 2 or 3 years we should probably get an MRI just to see what's going on? Is that something that's done usually?
There are some groups of patients that have a tendency to develop aneurysms at these branch points for the blood vessels.
Okay.
So we don't know if this patient's in that category or not. Sometimes you don't know it, and you just follow that patient, every 2 years, every 3 to 5 years.
Gotcha.
And you just surveil to prove to them and to me that they're not developing any other of these weaknesses in the walls. Okay.
So here's the hard question. Is there a reason why the weaknesses develop? It's just one of those things. Is there a risk factor for that? Is it hereditary? And if there's no answer, there's no answer. It's just something I thought I'd ask.
It's a fluid dynamics kind of problem. Okay. The blood inside the blood vessel has a force associated with it. Okay. At the branch points, then, the force of that blood is directed at a single point in the wall where the branching occurs.
Okay.
So if that wall then doesn't have the strength to withstand the force of the blood, then that wall undergoes deformation. Okay? It gets weak, it changes shape, and the balloon starts to grow.
Okay.
So it's largely a flow-related problem.
Okay.
Okay.
Interesting. Dr. Jimenez, I'm going to send this one your way because we were talking about seizures earlier. This is not a pediatric person, it's someone 65. But the question is, what's the workup for an old man? He calls himself old. 65 is not old. What is the workup for a man of 65 years old that has a seizure disorder? I don't know what kind of seizure disorder. It doesn't give me information on there. But I guess the question is, he knows he's having seizures. He needs to figure out, I guess, why. So that's the question from the audience.
So again, I think that, as I mentioned earlier, right, the first thing that I think we need to, the fork on the road at the very beginning is to decide, is this a surgical problem or is this a medical problem? So getting a MRI of the brain.
Right.
With all different cuts and with and without contrast to see, look for abnormalities, look for brain tumors, look for things of that nature. If it turns out to be a surgical problem, then come see us.
Right.
We'll take care of it.
Exactly.
If it turns out that the brain is clean and there's nothing there, then it's more of an electrical problem than a neurologist. And then there's a long list of things that can cause that. Sometimes what kind of medications, maybe side effect of a medicine, could be nutritional related, vitamin deficiencies, all kinds of things.
Hey, you were cute
And then
earlier.
they
I'm like,
go
well,
there.
what could cause that? And you're like, 14 pages worth of things.
Right.
So no, I respect that too. We're running out of time just a little bit. So Dr. Trier, I want to give this one to you. And I think I may have scared people by saying putting screws and rods in their backs. But it says here, for herniated and bulging discs, what are some other treatments if there is a patient that does not want to get the steel rods in the spine? Sorry if I scared you, but I know there's all kinds of ways of doing things. So I thought that was a nice answer to ask.
Yeah, and I like to begin the conversation primarily by asking what kind of things that have gone on with that patient in a workplace. When did you first get the pain? What kind of things have you tried to make the pain go away? And I like to refocus the rehabilitation on core muscle strength. Okay? Again, making the muscles do the job. If we're also doing a few stretches that give the nerves in a dynamic way a little more space, then the pain is better. I ask about sleep, because sometimes pain disrupts sleep, right?
Right.
And if you're not sleeping well, then you're not coping well during the daytime, right? So if there are things that we can do to improve on sleep habits, then we go down that road, and then patients are more likely to manage appropriately how they're using their back in the course of the day.
Right. So here's the thing. We don't have time for one other question, but you said stretches, and I would like for you right here on the air, when people come to you, you're sitting in a chair, I'm sitting in a chair all day, and you're right, I'm on Zoom
Yeah.
meetings all day long, I'm doing this all day long.
Yeah.
Every now and again, I should stop and do what?
Um,
I feel like I do this,
Yeah.
but then I get, you know.
Yeah. And at lunch, at your 15-minute afternoon break,
Right.
An exercise ball in the corner of your office, just laying backwards on the ball to, again, stretch the spine that direction, okay?
Right.
If you don't have that luxury, then just stretching your shoulder muscles in particular, holding it, okay, pushing them down, okay, will help all of these muscles to calm down and assume a different position than the one that we're using every day in our work position. And me too, you know.
Gotta tell you, just that tiny little bit right there felt
Yeah.
really, really good. All right, so we have a whole minute left, so I wanted to make sure I had some telephone numbers and websites I can give out to everybody. The clinic number is 521-7731, and there's also a couple of websites here. One is www.nexus, which is NEXUS, neurosurgery.com. Another one for El Paso Children's, El Paso Children's/neurosurgery, and that's specifically pediatric related. And if you want to watch this program again, because sometimes things go so fast, you can go to pbselpaso.org, go to watch, and then find the El Paso Physician logo, and that's where you'll be able to see not only this show, but many shows that we've done in the past, and also to epcms.com, and that's the El Paso County Medical Society's website, and there's all kinds of information that you can find there again. Again, Dr. Trier, thank you so much. Dr. Jimenez, thank you so much. And again, Kristen Helmstorfer, she did this all by herself today. We usually have two medical students doing this, but you rocked it, love. You really did. So thank you very much for doing that. Next month, we have several shows. It is October, so we've got a big breast cancer awareness month happening next month. I'm Catherine Berg, and you've been watching the El Paso Physician. Yay. Yeah? Yeah. Okay.
Great job.